chance. Please type your questions in the Q&A section of the chat and include which panelists you would like to answer your question, and our moderator will ask the question on your behalf. Now, I'd like to take this time to introduce our panelists and moderator for the evening. Mrna Vaccines is a dynamic and accomplished physician with extensive experience in the medical field. At present, she lectures at the Northwestern University Medical School as an assistant professor of clinical medicine. She is board certified in internal medicine. Since 2000, she has successfully served as a staff member at Northwestern Memorial Hospital. Dr. Belle Baylark was named one of Chicago's top physicians in the Chicago Hospital News. Also, she was named one of Illinois' most powerful and influential women by the National Women's Conference. I'd also like to introduce Stephanie Crawford, a professor in the Department of Pharmacy Systems, Outcomes, and Policy at the University of Illinois at Chicago College of Pharmacy, and the Executive Associate Dean for Faculty Affairs and Strategic Initiatives. Her research interests focus on social justice, access, and disparities reduction in the medication use process. In December 2020, she was appointed as a member of the Chicago Department of Public Health COVID-19 Vaccine Scientific Advisory Committee. Richard Hubbard is a board-certified physician in internal medicine and pulmonary diseases. He has spent his 30-year professional career at the National Institutes of Health and several biopharma companies in clinical research, conducting preclinical laboratory studies in novel diseases and in clinical studies involving human subjects in a variety of diseases, including asthma, COPD, arthritis, heart disease, and allergic conditions. Starting in August of 2020, he enrolled as a subject volunteer in a COVID-19 trial, which is still ongoing. This study was instrumental in the Mrna vaccine obtaining the USA Emergency Use Authorization for general use. Dorian Miller, a general internist, has been providing care to underserved minority populations for more than 20 years. Under her leadership, physicians, educators, and community members work to improve population health outcomes for residents on the South Side of Chicago through community-engaged research, demonstration, and service models. Dr. Miller's research focuses on the intersection of health disparities and race. Dr. Miller's work in the area of improving asthma outcomes through the school and community interventions was noted by the American Academy of Asthma, Allergy, Immunology with a special recognition award. So I would like now to hand things over to our moderator, Dr. Dorian Miller, and I'm sure we're in for a treat tonight. So Dr. Miller, it's all yours.
Thank you so much, Gwen, and welcome. I am honored to be with you this evening, and I would like to get started by welcoming you to our presentation this evening. Dr. Mrna Belle Baylark is going to be our first presenter so that we can do a little bit of level setting in terms of the information that's needed that the audience needs to know about the vaccine. So Dr. Baylark, if you would please get started.
Okay, I'm going to share my screen here. Just a second. Okay.
As Dr. Balark is getting set up, just many, many thanks to Alpha Kappa Alpha Sorority for sponsoring this evening's event and providing us with a platform to share this information with community. At this point, we have over 160 participants who are on the call, and the numbers continue to tick up as we move forward.
I had just a little technical issue here, so I'm just working to bring it up. So just give me another minute, please. Okay.
Terrific. Thank you.
Okay. Well, thank you for your patience, everyone. And again, I'm Dr. Kimbra Bell Balark, and I'm a board certified physician practicing internal medicine at Northwestern University Medical School and Northwestern Memorial Hospital. And it is indeed a pleasure to have this opportunity this evening to share with you information in regard to the COVID-19 vaccine, separating fact from fiction. I would first like to say thank you to Alpha Kappa Alpha Sorority Incorporated Chi Omega Omega Chapter and Attorney Gail Hasbrook for asking me to speak this evening. So what is COVID-19? I would like to start with a brief overview. So COVID-19 is the disease that is caused by a virus known as SARS-CoV, which stands for Severe Acute Respiratory Syndrome Virus 2. As you all may recall, in 2003-2004, we had a much smaller and less deadly pandemic known as SARS-CoV. So this is SARS-CoV-2, which is a relative of this virus that caused that smaller pandemic in 2003-2004. There was a brand new virus on the scene. We had never seen it before. Therefore, it was often referred to as well as the novel coronavirus. As you look at this commonly seen schematic in the right corner here, you notice a red ball with these, a white ball with these red spike-like projections. These are known as spike proteins. And remember that term because we will come to that a bit later in the presentation. So many ask, where did this virus come from? So the virus is believed to have originated in Wuhan, China in November of 2019, and is believed to have been transmitted from a bat to an animal host and then subsequently to human host, and then passed from human to human spread via respiratory droplets. So I would like to share this schematic with you just to give you an idea about the transmission. So if you look at the top row and the individual on the right who is wearing a mask, and this is the healthy person. And across from her is an individual with COVID-19 who is not wearing a mask. As you can see, there's a very high risk of probability of transmission, especially if you're within 6 feet of that person and for greater than 15 minutes. We do know that this virus is transmitted by respiratory droplets. So whether you're talking, laughing, sneezing, or coughing, this is how we can transmit the virus. So in the middle photo, you see the individual who is healthy is not wearing a mask. The individual with the mask or with the disease is wearing a mask. And actually the transmission drops tremendously. But ultimately, the greatest way to reduce or prevent transmission is when both individuals are wearing a mask and are at least 6 feet apart in regard to interaction. And for now, even with the advent of the vaccines, it's still very important that we wear a mask, and I will address the reasons why behind this a bit later in my presentation. But the point I wanted to get across here is the importance that we all continue to wear our mask. So COVID-19 testing. So there are two types of tests. We have diagnostic testing and we have antibody testing. So the diagnostic testing most commonly used comes in the form of the nasal test, the nasopharyngeal test, and the salivary test. The nasal and the nasopharyngeal test involve a Q-tip swab that's inserted into the nasal or into the nostril of the nose. which is the nasal swab. And it goes back a bit further into the back of the throat with the nasopharyngeal test. Both tests are very accurate. The saliva test does not involve a nasal swab. It's just using some of the saliva and testing for the virus that way. However, though it's a more comfortable test to get, I would say, it is not a test that is quite as accurate as the nasal or the nasopharyngeal. The antibody test is a blood test. And this is a test that is not used to tell you if you currently have COVID-19, but it's a test that lets you know if perhaps you had it in the recent past. So say early on when many of us could not get tested as we may have desired to do so based on the symptoms that we had, and say maybe a month or so later you're in your doctor's office and you request the antibody test. So it's very likely that that test will come back positive, and if it does, it indicates that you indeed had the coronavirus or COVID-19. If the test comes back negative, and it has been within a month or two of the suspected infection, then it means that you did not have the infection. However, getting the antibody test maybe 9-10 months later, when you think that maybe you had coronavirus last May and you come into my office, Dr. Bell, can I have the antibody test? I think I may have had COVID-19 back in May and I heard I could get this antibody test. My response would be that it probably would not be accurate as far as detecting if you did have it in the past, because we do not know really how long the antibodies that are produced from this natural immunity of having had the disease, we don't know how long these antibodies last. We know that they probably last for at least about 3 months, but we don't really know how long. Therefore, doing an antibody test outside of this window may not prove to be as accurate. So COVID-19 in Black America. We all know that COVID-19 has had a devastating impact on our communities. And we also know that this devastating impact has nothing to do with our Blackness or our genetics. And I want to make that clear. It hasn't devastated us because by being a Black person, I'm just more likely to have, to get or to receive COVID-19 because of my genetic makeup. Well, that couldn't be further from the truth. That is not the case. However, I want to first share a couple of schematics here that demonstrate this impact that it has had on African Americans. So on the left, we can look at the state of Louisiana. 32% of their population is African American. Yet 70% of African Americans represented deaths from COVID-19. Our great state of Illinois, 15% of us are African American in this Illinois population. But yet we are 42% of those who have died from COVID-19. And then if you look all the way down in Chicago, we make up 30% of the population, African American individuals, make up 30% of the population of Chicago, but yet we're about 70% of those who have died from COVID-19. And if you look to your right, the first cluster of bars, the blue represents white Americans, the orange represents African Americans, the green represents the Latinx population, and yellow represents our Asian population. The first group shows the number of cases per 100,000 population. As you can see, we lead the pack. In the second grouping, we see the numbers of hospitalizations from COVID-19. And as you can see, we lead the pack. And in the last grouping are the deaths from COVID-19. And again, we lead the pack. So why is this? This is largely felt to be due to something known as social determinants of health. Blacks relative to whites are more likely to live in neighborhoods with a lack of healthy food options, green spaces, recreational facilities, food options, lighting, and safety. Blacks are more likely to live in densely populated areas, which increase our risk for contact with others. We also represent about 25% of all public transit users. We're also less likely to have equitable healthcare access. We're more likely to be a part of the essential worker workforce, where we represent nearly 30% of bus drivers and nearly 20% of all food service workers, janitors, cashiers, and stockers. So during a highly contagious pandemic like COVID-19, Black workers and subsequently our families are overexposed. So next, I would like to move into the second half of my presentation as relates to the COVID-19 vaccine, facts and fears. Mistrust within the African American community. And I must say it's a justifiable mistrust within the African American community, largely based upon hundreds of years of systemic racism. We have this vaccine reluctance. One study that is frequently cited is the Tuskegee syphilis study. And this study ran from 1932 to 1972, so for 40 years. And the goal of this study was to track the natural progression of syphilis in Black men. In other words, the treatment was withheld. And the last surviving member of this cohort passed away in 2004. So this is in our relatively recent memory. This wasn't that long ago. And then many of you may have heard of J. Marion Sims. He was a 19th century doctor, I put in quotes, who performed gynecologic surgery on enslaved Black women without anesthesia. And as I said earlier, just the systemic racism, the healthcare inequities and mistreatment is the reason behind our mistrust within the African American community. History has broken that trust of the Black community. Our best weapon is to be educated and informed. So I would like to talk about the vaccine development process. I strongly believe that when we become familiar with what is unknown to us, then that familiarity helps to decrease our fear and helps to bring about a greater desire to move forward with the vaccine. But first, we must understand, so what is this all about? So the vaccine development process. There are 5 stages of vaccine development. So initially we have our preclinical testing. And so the vaccine is given to animals such as mice and monkeys to see if it actually produces an immune response. And then we have our phase 1 safety trials, where it's tested on a small number of persons for safety and dosage determination, and to confirm that it is indeed stimulating an immune response in humans. Then next we have expanded trials, phase 2 trials, where the vaccine is given to hundreds of people, split into groups by age. And then there's phase 3 efficacy trials, where actually for Pfizer and Moderna, whose phase 3 trials were done here in the United States, this included 40 to 50,000 individuals. And you may ask, well, how many of those were African American? Each study had about 10%. So we had 4,000 to 5,000 African American individuals in each of these trials. And actually, later in our presentation today, you'll hear from one of those participants, Dr. Richard Hubbard, who will share with us his experience and involvement in the vaccine trials. And then the next phase is approval. And that's where basically we go, or the companies go to the FDA to seek approval. In the case of the Moderna vaccine, as well as Pfizer-BioNTech, they approached the FDA in search of a EUA, or an emergency use authorization. As you know, we have had over 450,000 deaths secondary to COVID-19 in this country. We are in a crisis. Therefore, they sought to be approved for an emergency use authorization, meaning that we could begin distribution of this vaccine now to help curb the crisis that our country is in. And as we all know, Pfizer-BioNTech was granted this EUA, or emergency use authorization, as well as Moderna. So currently available in the United States are 2 vaccines: the Pfizer-BioNTech vaccine and the Moderna vaccine. And then we have 3 others that are coming down the pike that we will probably be hearing more about in the next 1 to 2 months. And that's AstraZeneca, which is currently in phase 3 trials, Novavax, which is currently in phase 3 trials, and Janssen by Johnson & Johnson, which I believe has completed its phase 3 trial and is approaching the FDA for an emergency use authorization. Of these 5 vaccines, all of them are 2-shot vaccines, except for Janssen, which is a 1-shot vaccine. And I'm going to come back to that in just a second. So first, I want to talk a bit more about the two that are currently available, Pfizer-BioNTech and Moderna, and how they work. So these two vaccines are what we are known as messenger RNA vaccines, or mRNA. And so I'm sure that many of us have heard that term, but may wonder, so what exactly is mRNA and how does this work? So basically, mRNA is a piece of genetic material. And this genetic material was engineered such that once it is injected into our bodies, it is able to produce a carbon copy of the spike protein, as you recall me mentioning earlier, which are those red spikes, those red projectiles that are coming off of the virus. It's able to produce a carbon copy of this spike protein, which then elicits an immune response from our bodies. So we make antibodies that will go and neutralize or attack this spike protein. So with the first shot, this process begins. And then 21 or 28 days later, when you return for your second shot, which you could almost look at as a booster, if you will, it then further stimulates our immune system to create this antibody response that will neutralize these spike proteins. And so this piece of genetic material, this messenger RNA, once it's done its job, which is to form this spike protein, it just disintegrates. So it goes away. It's not hanging around in our bodies. It just basically disintegrates. And so that's how this virus works. Now, the Jensen vaccine works a little bit differently. As I said, it's a one-shot vaccine. It's a DNA vaccine, as opposed to the messenger RNA vaccine. And it's made more similarly to other vaccines you've had before, like the flu vaccine or the tetanus vaccine. Using that technology, which is not a new technology. And so basically, it involves taking a piece, a tiny little piece of the actual coronavirus that's inactivated and in no way can make you sick or ill. And that's being injected into your body. And again, once it's there, the body sees it as something foreign and it produces antibodies specific to this piece of genetic material from the actual coronavirus, so that when you are, or when you do come into contact with the vaccine, if you come into contact with the vaccine, again, your body is ready to fight it with the vaccines, with the antibodies that you have produced as a result of having gotten the vaccine. AstraZeneca is made similarly. And Novavax uses a slightly different process. It's called a protein subunit vaccine, but it's a slightly different process. But in the end, it works the same with the production of a very almost identical copy of a spike protein. And therefore, our body's immune system kicks into gear to form those antibodies to protect us when and if needed, if we were to come into contact with the coronavirus. So as I close, I wanted to speak a bit about some of the common myths that are related to the vaccines. And these myths are more so related to the first two that are out, because those are the ones that are out currently, and that's the Pfizer-BioNTech and Moderna. So number one, we can't trust the COVID-19 vaccines because they were rushed. So actually, even though the messenger RNA vaccine is something new, studies as relates to messenger RNA have been going on for well over 30 years. So it's really not a novel concept, to be honest, even though it's the first time we've used it as vaccines. But the research on messenger RNA has been going on for years. And this is something also that Dr. Hubbard will tell us more about later in the presentation. Number two, the vaccine will give me COVID-19. So as I said earlier, with the Pfizer vaccine and the Moderna vaccine, we're using this messenger RNA, which has nothing to do with the actual coronavirus. Again, once this messenger RNA is injected into us, the messenger RNA then produces, it's been programmed to produce what looks like a carbon copy of the real thing, which is the spike protein, and that's what produces that immune response. But we're not actually being injected with COVID-19 virus when you get the Pfizer or the Moderna vaccine. And as I said a little while ago, with the Janssen and the AstraZeneca vaccines, you are getting a very small portion of that virus, but it's inactivated, and so it does not cause disease. Number 3, we don't know what's in these vaccines. Well, actually, we do. And if you go to the CDC website, there is a listing of every component that is within these vaccines. Also, if you go to Pfizer's website, or if you go to Moderna's, you can get a complete listing of what's included within the vaccine. These vaccines will alter my DNA. Well, they do not alter the DNA. Once they are injected into our bodies, they do not go into our cells and integrate within our own DNA. That is not what happens. Basically, as I said, once it's injected, then a process takes place to produce this spike protein, and then the original DNA or messenger RNA gradually just disintegrates. So we have left the actual antibodies that will protect us if we are to come in contact with COVID-19. Number 5, I already had COVID-19, so I won't benefit from the vaccine. Well, this is not true, because it may be true that first couple months of having the disease, but the antibodies we really don't believe last much longer than 3 months. And we also aren't really certain just how effective these antibodies are that were produced from your natural, infection. We just aren't sure how effective these antibodies are against future infection. And so, and especially outside of that 90-day window post-infection. So with that being said, it's very important that you do go ahead and receive the vaccine, at least within the first 90 days of having the infection. But you can get it as soon as the first few weeks of having the infection. So yes, still very important to be vaccinated. Number 6, since COVID-19 survival rate is so high, I don't need a vaccine. Well, as we know, about 85% of individuals who contract COVID-19 are going to do well. They're either going to be asymptomatic, but they found out they had it because they went to get tested because they were just curious, or they felt that maybe they were around someone who they later learned had COVID-19, and so they feel fine. They wanted to go and be tested. So many people are asymptomatic, meaning they have no symptoms of runny nose or headache or loss of smell or upper respiratory type symptoms, diarrhea, abdominal pain, fever, like they have none of these symptoms. Or they may have symptoms, but say the symptoms are mild, and so they're able to recover at home, and hospitalization is not required. Well, that's it. That's for about 85% of individuals. So this is true. The survival rate is very high with COVID-19. But also, when you think about 15% of people are either severely ill or dying, and we look at the number of people in this country, that's pretty high as well. And so, yes, you do need the vaccine, and you need it for 2 reasons. Number 1, you don't know if you might be that individual that falls in that 15%. And number 2, even if you weren't that individual that falls in that 15%, your grandmother might. So if you have the disease and you're asymptomatic and you go around grandmother, she could end up being one of those 15%. So yes, it's very important that you get the vaccine despite the high survival rate. Number 7, once I get the vaccine, I won't have to wear a mask or worry about social distancing. So this is untrue as well. And the reason that this is untrue is because even though you have the vaccine, yes, you are protected, but you can still get COVID-19. And what I mean by that, it can still be transmitted to you. It can still be transmitted to you. However, you won't get sick because you have antibodies that have been produced due to you having received your vaccine, and therefore you will not get sick, but you could transmit it to someone else who has not yet been vaccinated. So we will only be safe and only be safe when we have a critical mass of individuals in our country who have been vaccinated. So that's 75% plus of individuals in our country who have been vaccinated. Then we can let the mask go. But then and only until then, we must still wear a mask, not so much to protect ourselves if we've already been vaccinated, but to protect those that we are around. Number 8, now that we have vaccines, the pandemic will be over very soon. Well, no, that's not true, because as we have all seen in the news, the rollout is fraught with some of its issues. Getting it out to individuals in the fashion in which we had hoped is not quite happening. And though things are getting better, and it will get better and better as even more vaccine candidates come to the forefront, so we just have greater availability of the vaccine. Also, some of the vaccines that are coming to the forefront don't require some of the very strict methods of maintaining them. Like with the Pfizer vaccine, as you've heard, they have to be kept at very, very, very cold temperatures. And once the vaccine is thawed, it is only good for about 3 days, 3 to 5 days before it has to be thrown away. And then similar with the Mrna vaccine, it doesn't have to be kept as low of temperatures in the freezer, but once it is thawed, it can last for about 30 days in the refrigerator before it has to be thrown away. We do know that with some of the DNA vaccines that are coming out, they're less fragile, I would say. And so they can last several months, in a refrigerator. And also they do not necessarily require the stringent freezing conditions. And the last one here, the vaccine will cause infertility. That has not been found to be true. The vaccine is not a live vaccine. Like I said, it's the messenger RNA, or in the case of Jensen and AstraZeneca, it's just a very small portion of an inactivated piece of the virus. So again, it's not a live vaccine, and that's where we tend to be a bit more concerned when it comes to possible birth defects and things of that nature. Now, with that being said, in our studies, we don't have much at all done in regard to pregnant women receiving the vaccine, but there's more and more women who are pregnant, but who want to receive the vaccine, whether they're in a high-risk setting or whatever their reasons may be. And so they are being enrolled in these studies. They are agreeable to that, so we can continue to learn more there. But from what we see now and what we believe, and based on past vaccine experience with certain types of vaccines, it is not believed to cause infertility or birth defects. Oh, and then one other thing I wanted to say, in those initial studies where they look at like mice and monkeys and what have you, they did not see any birth defects or issues with the unborn child in pregnant mice or monkeys. So in conclusion, masks continue to be our best weapon for preventing the transmission of COVID-19. Even though the vaccines are here, we're not ready to let go of the mask. Black America's mistrust of the healthcare system is understandable based on our history in this country. However, education is our most potent weapon, and misinformation is our greatest enemy. Lastly, mass vaccination is necessary to save our lives. Thank you very much, and that concludes my presentation.
Oh, Dr. Balark, thank you so much for that very important information. I've been monitoring the Q&A as well as the chat during your presentation, and I must say that many of the questions that were posed, you were able to address in your presentation. But in order to kick off our conversation and also to bring in our other panelists, I'm going to ask just a few questions of you, and then I'll turn to both Dr. Crawford and Dr. Hubbard. So for Dr. Balark, what was your personal experience in receiving the vaccine? Have you received it yet? And if so, did you have any side effects?
So yes, I have received the vaccine. I received the Pfizer-BioNTech vaccine, and my second shot was received about a month ago. So it usually takes about 30 days post your second shot in order to achieve immunity. So I did well with it. So with my first shot, I did get a significant amount of tenderness at the injection site. We were trying to take down our Christmas tree that evening, and just lifting my arm to remove the ornaments was quite painful. So I did have to take some Tylenol, and it eased it up right away. And then 3 weeks later, I received my second shot. Same thing with the tenderness or pain at the injection site. Then I had some very mild systemic symptoms, fatigue, mild headache, a little bit of nausea. But these are to be expected with that second shot in many individuals, though not everyone has these types of side effects. But I do know some individuals who complained of muscle aches, low-grade fever, and I know many individuals who had no symptoms at all. So it can be a spectrum after that second vaccination, but my experience was fine.
Great, thank you. And then another question for you, Dr. Balark. One of the questions in the chat has to do with the mRNA vaccine as a genetic material. And is mRNA a genetic material that's specific to African Americans, in that are there variants in mRNA versus is this something that's much more generic?
No, but first of all, it's not specific to just, African Americans. No, it's a part of the way that our cellular structure in the human race, functions. So messenger RNA is a part of just the way we function at a physiologic level. And so, no, it's not specific just to us. And there aren't different types that are for Black persons versus white persons versus Asian persons. And also Dr. Hubbard can probably speak a bit more to this later. But no, basically the messenger RNA is really looked at as an instruction set. And so it was formulated with instructions to make this spike protein that would then induce an immune response.
Great, thank you. I think that that's a nice transition to bring in our other two panelists. And so I'm going to direct some of my questions next to Dr. Stephanie Crawford. And in particular, Dr. Crawford has had a very special role in terms of her work with the Chicago Department of Public Health, because she was recently appointed to the Department of Public Health Scientific Advisory Committee for the COVID-19 vaccine. Dr. Crawford, can you talk a little bit about why the committee was assembled? Any findings or recommendations from the committee, and assist our webinar participants in terms of what kind of oversight is taking place in terms of the scientific advice around the COVID-19 vaccine. Dr. Crawford.
Thank you, Dr. Miller, and thank you to those who invited me to join this amazing panel and to be able to speak to over 220 participants on this webinar. So, in terms of why was the group assembled, as we remember, COVID-19 became widely recognized in the United States around March 2020. And a few months later, the U.S. Food and Drug Administration, the FDA, granted the emergency use authorization for 2 supposed treatments for COVID-19. These were chloroquine phosphate and hydroxychloroquine sulfate. Probably heard some people talking about those, as well as convalescent plasma for COVID-19. These controversial EUAs were granted outside of the normal process, without FDA advisory committee input and without compelling evidence from adequate and well-controlled randomized clinical trials. In fact, the EUA for chloroquine phosphate and hydroxychloroquine sulfate, it was revoked June 15th by the FDA. So public opinion of the FDA was really low at a nadir due to thoughts of approvals based on perhaps more political pressure versus the science. So efforts by the city of Chicago were set in place for transparency and assurance in protecting and promoting the public health with the availability of these COVID-19 vaccines. So committee members with a spectrum of expertise were appointed for a short-term effort, that is to review the processes involved in the EUAs for the first COVID-19 vaccines, maybe the first 2 or 3. So the Chicago Department of Public Health Scientific Advisory Committee has provided scientific review, not for safety and efficacy, that's the job of the FDA, but we review the processes followed by the FDA, as well as a lot of the data that they made publicly available to provide assurance to the people of Chicago and the approximate 400,000 healthcare workers in Chicago. We concluded that sound scientific standards were undertaken by the FDA in the EUAs for these first two COVID vaccines. Our reviews of the information from the FDA and the vaccine sponsors and our meeting discussions, through those, we concluded that the processes followed by FDA that led to the that led to the EUA's emergency use authorizations for the Pfizer BioNTech COVID vaccine and the Mrna COVID vaccine were grounded in science with rigorous consideration of the benefits and risks.
Very, very important information. Just curious, Dr. Crawford, as you think about the work that you've done on the scientific advisory panel, did it impact or influence your decision-making about considering getting the vaccine, and if so, how?
Yes, and for the participants, because several of us met just a little bit, and I kind of admitted something that I wish to admit to the group. I admit that I was initially vaccine hesitant. I have served through my professional service, I've served on dozens of FDA's National Drug Safety and Risk Management Advisory Committees regarding drug product approval and or continuation of a drug product on the market and under what conditions. EUAs are a little different. While, quote, substantial evidence, unquote, of benefit is needed for most drug and vaccine approvals, emergency use authorization can be used if the benefit likely outweighs the risks, while safety and efficacy studies are still ongoing. So among my coworkers, I encouraged and was very happy that others were willing to take the vaccines whenever they will become available when we had discussions in December. But I said I was not personally rushing out to get the vaccination, preferring to wait to see a few more months of safety data. But since serving on the CDPH Scientific Advisory Committee, I delved into the data, reviewing hundreds of pages on the effectiveness, the side effects, the processes, the number studied, the groups included, to make sure they were well represented by people of color and different disease states. I have had a change of view. Okay? I've become much more convinced and confident that taking the vaccine as soon as possible is a very good decision for most. So from the current data, the benefits of being vaccinated far outweigh the risks. The two vaccines available under EUA have been well evaluated and data do continue to be gathered, but the vaccine is one of the best ways to protect oneself in addition to the, as we hear, PPE, personal protective equipment, social distancing, and hand washing. I did see a question in the chat, if I may, I'd like to address just talking about this. I saw a brief question about have the vaccines been tested in people with hypertension and diabetes? Yes. Though they looked at different disease states, the different, it might be one that was in one trial and not the others. They definitely included in the patient recruitment, the participant inclusion, people who had comorbidities that included chronic lung disease, okay, or moderate severe asthma, as well as severe cardiovascular heart disease, severe obesity, diabetes, liver disease, and HIV. And the results, just like with everyone else, for the COVID vaccine, very promising. Benefits far outweigh the risks.
I think that question, the question that was posed, is so important because oftentimes I think we think about things in terms of race and ethnicity in terms of testing, but the question of whether or not things are really working for people who might benefit from them the most, and also who are at risk for having severe complications, which is the point around this, because that's what we've been seeing in most of the patients that have been coming into the hospital, people that have either been hospitalized or unfortunately passing away from COVID-19 complications have had a lot of these underlying conditions. And so I'm very glad that you highlighted that information in your comments. I'd like to pivot to Dr. Hubbard for just a moment, because not only as a physician and as a lung specialist and researcher have you had engagement with this, but you also decided to volunteer for one of the clinical trials. Talk a little bit about your concerns and questions around safety, perhaps some issues around equity of being involved in this research.
Well, I made a decision to enroll in the Mrna trial last summer. And having done clinical research and conducted probably 75 trials myself and gone before the FDA and European regulatory authorities, I'm very familiar with the process of drug development and the steps that reputable drug companies and biopharma companies take in developing drugs. So I was comfortable that Pfizer, who I actually used to work for, and Mrna were taking the proper steps in terms of developing these vaccines. The technology I knew was not exactly, I understood was not that novel. It's been around for 20 years, starting with the first SARS vaccine, SARS disease back in the early 20s, 1990, I believe, and also for Ebola. So this technology has in fact been precedented, as we say, and is not something that we were starting from scratch with. So I volunteered to be in the trial, comfortable that I understood the risks, that I understood that the companies that were doing these studies were reputable, and that there was supervision from the FDA about how to do these studies. I also felt it was important that we get African-American representation in the studies, as well as representation of older people, of which I am one, and someone who has underlying conditions as well. So I kind of fulfilled at least 3 of the check boxes of the kind of people they want to have in these studies. So I volunteered for the study. It actually is was easy to do. It's an easy study to be enrolled in, because the people who are being enrolled don't have COVID disease. They're otherwise healthy. And so what you're doing is you're treating with either placebo or the vaccine for people who are otherwise healthy. It's not like treating somebody in a cancer trial, which are much more difficult to do. So I got my first blinded dose, meaning I didn't know whether I was getting vaccine or placebo, at the end of August. I had almost no side effects. And it was my 3rd round of vaccines this year. Earlier in the year, I got a flu vaccine, and I also got a shingles vaccine. And over the years, obviously, like everybody else, I've had a lot of vaccines, and I understand what the symptoms are. I had virtually no symptoms for my first dose of the Mrna or placebo. And then when I got my 2nd dose at the beginning of October, I also had virtually no symptoms other than the pinprick soreness from where the needle entered my arm. That was it. I was convinced that I got the placebo because of the lack of reaction. No fever, no muscle aches, nothing like that. So I thought, well, I probably got a placebo. Then in January, after the emergency use authorization had been granted, they called all the trial participants up and said, would you like to know which treatment you got? And I said, of course. And so that's what they call unblinding. I unblinded, and it turned out that I got the actual active vaccine, which was quite a surprise. I didn't quite know how to feel about it, but it was quite reassuring that it was well tolerated, and that I have now some degree, but not absolute, protection from getting further symptoms of COVID. I just wish my wife could get one as well. Then I would feel much better if everyone in our household were vaccinated, but that's not the case. She has to wait for availability for her group. I think it's a 1B group or something like that, to get vaccinated in the city we live in. So as far as equity in this trial, I know that the people who were running, Dr. Novak, et cetera, at the University of Illinois, Chicago, were very concerned that they had an equitable enrollment strategy to make sure that people of color were in it, that elderly were in it, people with underlying conditions. There were some exclusions, which are always the case in early drug development. They didn't put any pregnant women in it, although there probably were some who may not have been pregnant or know they were pregnant, but got into the trial anyway. I don't think they had too many frail elderly in the study. And they certainly didn't have any children. Those things are now being corrected in subsequent trials. And I think it's very important for that information to come out so that we have a fuller understanding of the broad population safety of these vaccines. But from what I've seen, from the published material, from the websites, the FDA and the manufacturers themselves, I'm quite comfortable that these are quality vaccines that will certainly fulfill a broad health emergency that we badly need. So it's as we say, the benefit greatly outweighs the risk of these. And the comment I think earlier about, well, I don't really need a vaccine, people say, because only 15% of people get significant serious illness. Why play Russian roulette? That's basically what you're doing. 15% is a 1 in 6 chance of doing something. And if there's a very good treatment that'll prevent you from having it, why not take it? So I think education is important. Broad education is not going to undo the social determinants of health necessarily, which really make people hesitant to get vaccines. They don't trust the system. It hasn't worked well for people of color in the past. And so education is an important step, but it's not going to be the only thing.
Though I think that those comments are spot on, and I see Dr. Baylock shaking her head in agreement on that. The issue of being able to become involved in the trials is something that, at least for us as African Americans, doesn't happen that often. And so the outreach around making sure that we as a people have been overrepresented in the trials to make sure that the vaccines are safe and effective, absolutely critical. I've got a few other questions that were posted to us through the Eventbrite chat in terms of continuing our conversation. We talked a little bit about children under the age of 5, and actually, from my understanding, that none of the vaccines have been tested actually in children under the age of 16. Is that correct, Dr. Baylark?
Yeah, so with the initial trials that took place, I think for Pfizer, their vaccine is approved for 16 and older, and with Moderna, 18 years old and older. I'm not aware of children in those initial trials, but it is my understanding that they're starting to take the age down and look at some adolescents and individuals in that age group for trials. But that's all I know at this time.
Great. Dr. Crawford, you want to comment?
Yeah, just to add exactly to what Dr. Baylock was saying, there have been small numbers, just not enough to make any conclusions on children as young as 12 being included in some of the clinical trials for both, but it's not approved yet for anyone except what Dr. Baylock was saying, for anyone that young.
A couple of questions have come up around allergies, and I was hoping perhaps turn this one to you, Dr. Hubbard, if you're able to address it. People have asked if I have moderate allergies, meaning things like dust, mold, pollen, those types of things, can I still get the vaccine? And then secondly, if I have more severe allergies, the kind of allergy that would require me to carry something called an EpiPen with me, is that a reason not to get the vaccine?
Yeah, I think whatever advice we give here, we just want to remind people they need to talk it over with their own primary physicians. So having said that, my understanding is the best advice is that people who have minor trivial allergies to things like house dust, et cetera, can get a vaccine. The vaccines need to be given in a supervised settings where you can be observed for at least a half an hour afterwards to make sure that you don't have a more significant reaction. The ones that tend to be contraindicated are people who know they've gotten significant reactions from other medications and vaccines. And again, this is a matter of medical history, and you talk over with your doctor. And for those, it's a tougher call. If you've really had a significant reaction which requires you to carry an EpiPen, I think you're probably better off not getting the vaccine. But little trivial things, itch here and there from something, is not a contraindication, considering that getting the disease is much worse than having a minor allergy.
And I would like to just kind of piggyback on what Dr. Hubbard said. If you look at the CDC website, right now, the two primary reasons that they say to really sit down and have a talk with your physician and see if you should proceed is A, if you've ever had an anaphylactic reaction to any type of intramuscular or intravenous medication. And so when we say anaphylactic allergy, we're speaking of an allergy where the throat closes, there's trouble breathing, the tongue is swelling. That's an anaphylactic or life-threatening reaction. And then obviously if you have an anaphylactic reaction to any component, of the vaccine. In these cases, you should definitely sit down and have that conversation with your healthcare provider as to whether or not you should proceed. And as Dr. Hubbard said, if you are to proceed, definitely doing it in a supervised setting, typically waiting for about 30 minutes after having had the vaccine administered, and an EpiPen should be on hand as well. However, if you've had an anaphylactic reaction to, say, ibuprofen, that's technically not listed as a contraindication to getting the vaccine. If you've had an anaphylactic reaction to bee sting or something like that, technically that is not listed as a contraindication to getting the vaccine. It's just those two that I just mentioned, but I still would say that if you do have history of anaphylaxis in general, just to have that conversation with your physician to determine in some shared decision-making how you should proceed.
I think that's very important. Primary care physician at the University of Chicago, and I have a few patients who have a history of severe allergy, and I've actually been referring them to my colleagues in infectious disease and also in allergy and immunology in particular to say, I think see a specialist in terms of decision making around whether or not you should receive the vaccine. So very, very important information. We've gotten a few questions about the different types of vaccines, and I think Dr. Balogh, you covered that a little bit, but people are wondering, okay, the Johnson & Johnson vaccine is only one shot versus the Mrna and the Pfizer, which are two. If I have a choice, which one should I get? So
I think the first thing I like to say is get vaccinated, right? And we don't always have a choice. We don't always have a choice. But the most important thing is to get vaccinated. And I don't know if I can just really make a plug for one or the other, to be honest with you. Again, the most important thing is to get vaccinated. Now, when they looked at the Johnson & Johnson or the Jensen vaccine, it showed a lesser efficacy than Pfizer and Mrna. It's about, in the UK, I think the efficacy was around 60 some odd percent. In the United States, they saw the efficacy around 71, 72% against mild to moderate disease. They saw an efficacy with the Jensen vaccine around 87% for severe disease. And then they saw actually 100% efficacy against death with the Jensen vaccine. So you have to weigh all of those things. I think the fact that it's the only one-shot vaccine we have is a real plus for lots of people. When you think about millions of people having to come back for that second shot and they get lost in the shuffle. So I think a one-shot vaccine is a tremendous plus. But those are some numbers in regard to efficacy, and I do think it's a great vaccine as well. So again, bottom line is get vaccinated.
very good. Another question here that came in over Eventbrite, and it relates to the experience that many people have had around the influenza vaccination. Over the years, I've had my patients to say, I come in here every single year, Dr. Miller, and every year in the fall, you're always saying, get a flu shot. Why can't they make something that's going to last for more than 1 year? So we've got some questions about once you get vaccinated, exactly how long is this going to last? Is it going to be a situation where we're going to have to give boosters year after year? Is this something that's going to last for several years? And so just a little bit of information on that. Actually, Dr. Hubbard, I'll start with you, and then after that, I'll go to Dr. Balogh.
Yeah, I think part of the issue with viruses in general is that they change. They change with time. We call it mutation, and they come, you develop variants. We've got a couple variants circulating in the country now. So the fact that viruses do change means that the vaccines have to change with the virus. And generally, it's an annual process. So every year, the CDC or the WHO surveys what viruses are prevalent, and they recommend that the vaccine makers adjust their vaccines to take care of the changes the virus has done. Now, is this going to be something that will have to happen for the coronavirus? My guess is yes, that one shot or two shots this year will probably not last you a lifetime. Again, that's all speculation, and we have no data that says that. But viruses do behave very similarly. So we don't expect this virus to be that much different than the other ones. So yes, you'll probably need to get revaccinated at some point in the future. I can't say how long it'll be. The trial I'm in actually is a 2-year trial to try and understand how long the protection from the vaccine I got in the beginning lasts. So I go every 3 months. I get antibody tests to see if I still have antibodies, et cetera, to try and answer this question. Is it 6 months? Is it 9 months? Is it 3 months? Is it a year or longer? So the studies are ongoing, but I would probably have to predict, and I think Dr. Fauci would agree with me, that this is something that will have to be, vaccines will have to be adjusted over time and be given at some interval, probably if it's like flu, annually, maybe less.
Getting a question in the box around the variants and whether or not the variants that are coming up would be the one from the United Kingdom, South Africa, Brazil. Are any of the strains more deadly than any of the others? So Dr. Baylor, and then maybe Dr. Hubbard.
So in regard to exactly how lethal some of the variants are, I don't have a lot of data on that, though I do hear that that variant in South Africa has shown it to be an even greater challenge as far as how effective some of our current vaccines are. They are still effective against that particular variant, but not as high of a level as it is against the UK variant, and definitely not as high as it is against the original strain. I had pulled a little data on that just last evening. And so I know with the Novavax and vaccine that's not out yet, and the Pfizer and the Mrna vaccine, they're at about 85% effective against the United Kingdom variant. The original strain that we have here, they're 95% effective. That's Pfizer, Mrna, and Novavax, which is not out yet. And then as far as that South African variant, all three are about 60% effective against that particular variant. So in regard to a paraphrase from Dr. Fauci, if the virus can't replicate, then that would definitely decrease the chances of more variants coming along. And to keep the virus from replicating, we must vaccinate.
Because if the virus is going to mutate, in order to mutate, you've got to replicate.
Exactly. But if we're vaccinated, then we prevent replication, therefore preventing mutation.
Okay. So another question that's come up, and this has to do with taking medication before or after getting the vaccine shot. So does taking Advil, Aleve, Tylenol, or Motrin before or right after have a negative impact on the effectiveness of the vaccine? Dr. Crawford, are you able to take that one?
A little bit, and I think Dr. Hubbard might have some to add to this. Essentially, there's been conflicting information. The drugs that you mentioned, Advil and Motrin, I tend to know generic names a little bit more. They're
ibuprofen, naproxen, or acetaminophen.
Yes, Aleve is naproxen and Tylenol is acetaminophen. And if you look at different sites on the internet, credible sites even, you'll get conflicting information. From what I've seen, more so, but I definitely defer to the two physicians on the panel, it is recommended that, we're talking, by the way, about over-the-counter doses, not prescription level doses of these drugs, and presuming a patient does not take one of these, or a person does not take one of these medications to treat things now in their everyday life, has not typically been taking it, it's advised that one not take any of these drugs before you get the vaccine. But the problem is, Dr. Baylock mentioned some of the side effects, fever, pain, chills. Some of these medications would help treat that. So I've not seen evidence right now that it would hurt a lot to take it afterwards. By the way, if you must take one, people are saying maybe take the acetaminophen, the Tylenol, or one of the generics, as opposed to one of the, as they call them, non-steroidal anti-inflammatory drugs, the ibuprofens and the naproxens, because it works differently. All of them reduce fever, all of them are pain relievers, but Tylenol does not have anti-inflammatory properties. And because of what Dr. Baylock was telling us with how that spike protein works, people are saying that might interfere less. But sometimes because of how people are feeling afterwards, they do take the medications, and that those people are also included in the, well, not those, but people who have taken these NSAIDs and the acetaminophen have been included in the clinical trials, and it did not seem to affect the results.
Thank you. I have a couple of questions about the timing of the second vaccine, because I know that there's been some debate around getting as many people vaccinated with at least their first vaccine as possible, and perhaps in some cases even delaying the second vaccine so that we can spread more evenly the number that we have available. If you don't get your second vaccine within the, for the Pfizer and the Mrna, the recommended 3 to 4 weeks, depending upon which one, do you have to start the series all over again? Say, for instance, if there's a 6-week delay before getting your second vaccine, does that mean that you actually have to start with the first one and then get the second one on time? So, Dr. Baylark?
I'll defer to Dr. Hubbard, who has a lot more involvement with the clinical trials. And so I'll refer to you, Dr. Hubbard.
Yeah, I think that there's been some discussion, quite a bit actually, about just giving people one dose so that everyone can get one, and then worrying about a second dose once the medications are widely available. There's really no data about this. Antibody studies show, at least for the Moderna and Pfizer one, that with the one dose, you do get about 50% protection. And then you need the booster to get up to the 90% protection. But I don't think anyone really is recommending that you widely vaccinate the population with the one dose at a time. I think the key to getting people vaccinated is to get the vaccines made and distributed. And so ramping up the production and distribution, I think, I just was listening to Dr. Fauci this morning. He said, that's really the key to doing this, not just under vaccinating people. It's more important to get the vaccines into arms, and that means making more of them. So I think that's it. The other thing is there's just not a lot of data, and we're pushing the envelope of what we know by recommending that, yeah, it may be okay to go 7 weeks, 8 weeks out. We just don't really know. And for those of us who like to be empirical about things like that, we can't really make recommendations in the absence of information.
Very important point. I've had a couple of questions about people who have underlying health conditions. One question came up is, if I'm under treatment for cancer, will the vaccine interfere at all with the medications that I'm taking to treat my cancer? So who would like to take that one? Well,
I can start on it. First of all, there are many, many different medications for cancer. Cancer is very diverse set of diseases. And so you can't just say, well, it won't interfere with my medication without knowing specifically what it is. I think the medications you have to worry about are potent anti-inflammatories. Those are the ones that will blunt the effectiveness of the vaccine. Will the vaccine promote a cancer and make it more aggressive? I don't think that's likely, although I don't know that the FDA databases are big enough to understand that. They certainly looked at 30, 40,000 people in the large trials, and I don't think they saw any promotion of cancer aggressiveness, but I can't say that for sure. So again, we don't have enough information, but the way these vaccines work and our experience with prior vaccines is that it's unlikely. It's just that the anti-inflammatory agents, which can be very potent, may blunt the effectiveness of the vaccine, not the other way around.
I agree with Dr. Hubbard.
Thank you. Another question that came up in the chat, and this has to do with the side effects. If you receive the same medication in the second dose as you do in the first dose, why is it that with the second dose of the vaccine, you tend to have more side effects? So, Dr. Balark?
Yes, I don't mind taking that one. So with the initial shot that you're getting, basically your immune system is being primed, right? So you're going to have that initial antibody response coming from nothing, coming from 0.0, and now we're like 50% as far as priming that immune system. So with the second shot, we're not starting from 0. We're starting with already a prime. And so when you give that shot, which is going to then trigger an antibody response, it's an even more aggressive response because we've already produced some antibodies from the first shot. So as we produce additional and those that are already there and they kind of all go into action, then that's why we tend to get, or we see fairly commonly more side effects with the second one. But it's not a bad thing. It's just kind of showing that your immune system is doing what it's supposed to do. But conversely, if you don't feel any symptoms, don't think it did not work for you, because as Dr. Hubbard shared with us, he received the Mrna vaccine and he later learned that it was Mrna, and he didn't really have symptoms with either except for pain at the injection site. So it doesn't mean that it's not working, but for those who do experience those kinds of symptoms, that's what's going on. And it is more likely, if it's going to happen at all, with that second shot.
And may I add just a little bit?
Please, go ahead.
Thank you so much. I have, as we know, I had a change of heart, so I have taken the vaccine because of where I work and who I interact with. And I was also one of the very lucky ones whose only side effect was sore upper arm, mild. The first shot, it was 2 days. Second shot, half a day, sore arm. But I have to say to the group, 2 other, quote, side effects that I experienced were relief and a sense of empowerment, because it really feels good to know that I'm doing all that I can do to protect myself from COVID, as well as to protect the people around me. And I also did see, I can't answer many in the chat, but I did see one that said, because it's a big one that maybe others also want to talk about, can individuals who are vaccinated still carry or transmit the virus to others? Yes, there is the possibility. We have to, the vaccines are not 100% to prevent COVID. The 2 approved so far, about 95%. But also, we're coming into contact with others, interacting with others. Things might be on our masks and anything. So that's why it's still so important to practice that social distancing, PPE, and the hand washing, because yes, after you are vaccinated, it's possible, though the odds are much lower, that you could transmit to others.
So the acronym WASH up, mask up, and back up.
I like that. I like that.
Yes, absolutely correct. I had the Pfizer vaccine around the same time as Dr. Balark, and the first one, not a problem. My arm was a little bit sore after the injection. I had a mild headache the next morning. The second injection, 3 weeks later with the Pfizer vaccination, my arm was a bit more sore. I had the same experience of trying to lift something and actually had some swelling there. And then some joint aches and pains, a low-grade fever, and actually some nausea as well. And the nausea started first and then some of the other symptoms. But they were very short-lived. As a matter of fact, by the time 24 hours passed passed, all of my symptoms were gone, felt just fine, got a little bit of rest, had no difficulty with it. So I took it as a positive sign that things were starting to work, that my immune system was getting revved up. And again, Dr. Crawford's testimonial of saying that having a sense of celebration and relief. I had someone to take a picture of me in front of a sign with a 2 thumbs up afterwards because I'd gotten the vaccination, because protection for my family, for my patients, and for myself was absolutely key. Symptoms are somewhat individualized, as someone put that information in the chat box, and that is, we've got a range of people who, of the 5 of us who are in this discussion, that had a range of symptoms. And so again, symptoms are individualized. Other questions or things that you would like to share with our listeners before I go on with the questions? Okay, I have a question that I think that might have been addressed a little bit earlier, but perhaps in a little bit more detail. And that's the question of how deadly is COVID-19 compared to the flu virus? And also, how contagious is it compared to the flu virus? So death rates, and then again, transmission and contagion.
You know, I can't give you the specifics on the death rates. I don't have that data before me. But as I said earlier, 85% of cases of COVID-19, you're going to recover and be fine, whether you're asymptomatic or have very mild disease or even moderate disease, but able to recover at home. And so that's the overwhelming majority of cases, 85%, 15% may be hospitalized or even death. COVID-19 is very infectious. I've read some studies that, or some reports that say it's even more infectious than the flu. But one thing that I can say is that they are both transmitted the same way. And so if you think about it, our flu season hasn't been so bad this year. And that's likely because we're wearing masks, we're washing up, masking up, and backing up, as you said, Dr. Miller. And so we're not passing COVID if we're doing these things, and we're also not spreading flu. And so we've had, from what I can see, and in my practice, a very mild flu season this year because we prevent it the same way we prevent COVID-19.
I've had the same experience. Don't think that I've diagnosed a single case of influenza this season, and I've been screening for it when people come in with symptoms. I interrupted someone who wanted to make a comment. I'm sorry.
Well, I was just going to say that if you look at the numbers, prior to this year, a typical flu season would cause about 50,000 deaths. And as a society, we've gotten comfortable with 50,000 flu deaths a year. With this COVID, we're pushing 500,000. Mm-hmm. So that alone will tell you that this is a very different animal than flu. We're not comfortable with losing 500,000 people. I hope we never do become comfortable with that. But that gives you an idea that this is a much more serious infection than influenza.
Sobering statistic, absolutely sobering statistic. And I think the information that Dr. Balark showed a little while ago in terms of the percentage of deaths that have affected particularly the African-American community, given our percentage in the population, is also just quite sobering. I've gotten another question in the chat box here that says, I've gotten conflicting information on the number of days for quarantine once you test positive for COVID-19. Do you count the days from your first day of symptoms?
Yes. Yeah, so if you develop symptoms, say on Saturday, where you notice, oh, I've had some runny nose, I have some low-grade fever, but you don't actually go and get tested until Wednesday because you're like, wait, what if this is COVID, right? And so you end up going to get tested on Wednesday, but you will start counting as far as how long you need to quarantine from when your symptoms first began. And so if you go from symptom onset, at the very beginning, it used to be a 14-day quarantine. And so now the CDC has adjusted that to actually 7 to 10 days. And I usually err on the 10-day side of things from the time that symptoms develop. So that's what we're going by now. And these guidelines are constantly updated on the cdc.gov website, which will give all the guidelines in regard to quarantine.
Just got a nice testimonial testimonial in the chat box of someone who said, received the vaccine, I have an underlying health condition, and I experienced a wide gamut of side effects, but definitely worth it if it means increasing my chances of living. So I think that comment is just well said. There are a number of other comments that are specific to people's particular health conditions that are here. I think that we should provide the disclaimers that we're providing information this evening for education by the general public. If you have specific issues around receipt of the vaccine based on your health condition, please by all means talk to your doctor with these specific questions, because he or she can give you information that's specific to you and your health concerns. Another question here, if you've never received the flu vaccine, is it safe to get the COVID-19 vaccine?
Yes.
Okay.
Unless your reason for not receiving the flu vaccine has something to do with some type of history of anaphylactic reaction to vaccines or something of that nature. But unless there is a reason, you know, in that realm, then no, it should not impact you getting the COVID vaccination.
Another question that came up in the chat, and this has to do with the way that people are using what's called personal protective equipment, or PPE, and so people wearing masks. Is it important to protect your eyes as well? We've seen a lot of people who are out there that are wearing these plastic face shields in addition to a mask. Unfortunately, some of them are just wearing the face shield and not wearing a mask. But what about the issue of protecting your eyes?
Yes, it is important to cover the eyes as well, but I think the reason we put the emphasis upon the mouth and the nose is because that's how you're spreading it, right? So nothing is spewing out of your eyes in other people's faces, right? But when we talk, when we breathe, when we sneeze, when we cough, it's coming from the mouth and the nose. And so that's why we put a primary emphasis there, because you don't give it to someone because something flew out of your eyes per se. But granted, you know, if someone is coughing and sneezing in front of you, if it comes into contact with any of your mucous membranes, such as your eyes, your nose, your mouth, yes, you can contract the infection. But I believe that's why mouth and nose is so emphasized, because that's where it's spewing from when you're talking, laughing.
You know, it's estimated that people touch their hands to their face as many as 30 times within the course of an hour. And so if you think about contacts that are landing on your hands and doing that without even thinking about it, I think that's part of it. We've got about 3 minutes left before we're going to ask Ms. Tasha Smith to come in and to give us some closing comments. And so I wanted to give our three panelists just the opportunity in about 45 seconds or so to provide any closing comments to our participants this evening. So Dr. Crawford, I'm going to start with you.
Thank you so much, Dr. Miller. One question I wanted to answer that some might have is there a cost? Is there a cost to me to get the COVID vaccine? And I wanted to share that per the city of Chicago and the Illinois Departments of Public Health, the vaccine is offered at no cost to people in the state. But vaccination providers will be able to charge an administration fee for giving the shot. Now, they should, if they charge it, get reimbursed from public or private insurance that a patient might have, you know, Medicare, Medicaid, commercial health insurance, or there is also a place that can go for uninsured patients. The administrative fees are not to be passed along to the patient, but unfortunately, this week we have heard troubling instances with people being turned away from getting the COVID-19 vaccine, including perhaps some large chain pharmacies, if they don't have public or private insurance. So if anyone has a problem, we want, if it is your choice, we definitely respect that's a personal choice, but if you choose to get the vaccine and attempt to get it at a provider who says if you don't have insurance, I'm not giving it to you, they're trying to recoup that administrative fee, we encourage that you contact your local health department to report that, because people shouldn't have to pay. And it's, you know, there are other options these providers could be given, you know, When you're looking for the vaccine, wherever you can find it, your healthcare provider, when it's available, pharmacies, it's going to become increasingly available, your employer, and some other groups. Again, with that last thing, I just want to say it's been a pleasure to serve with Dr. Miller and Dr. Hubbard and Dr. Bell Baylock, and to be able to speak to the group tonight. Thank you.
Thank you. Dr. Baylark, a few closing comments?
Yes, I would just like to say that I hope that information has been shared tonight and that you have learned something that you did not know before you joined this webinar this evening, and that with that information that you have learned, that you are now armed to make an informed decision, and that it will hopefully encourage you and allow you to feel more comfortable moving forward and receiving the vaccine. This is the only way that we're going to beat this pandemic, and we can beat it. But this is the only way that we can come out victorious. Thank you.
Thank you. Dr. Hubbard.
Yes, I'd like to thank the participants, and I also hope that we've been informative to people and answer questions they have. My only recommendation is if you get a chance to get the vaccine, take it. If you're a little bit concerned and you don't like to take things right off, you want to see how safe they are when more people taking it, that's okay. You don't have to be the first one. You can wait until it's been out a few months and see that, yeah, it seems to be okay. That's all right. That's a reasonable strategy for people who have so-called vaccine hesitancy. I just think that what does trouble me is getting overly persuaded by conspiracy theories and bad social media, which just provide the wrong kind of information and make people too anxious about getting a vaccine. So I hope that we've been able to provide hopefully accurate and honest information about this. And we don't want to be lecturing and hectoring people to get a vaccine. If you have reservations, well, that's fine. But over the course of the year, you should get a vaccine, or we're never going to lick this pandemic at all.
Thank you, Dr. Hubbard, and thanks to wonderful panelists this evening that I think have provided some very important information for our community on not only the vaccine, COVID-19, but also reasons to participate in not only getting it, but also an advertisement for clinical trials. There's information in the chat box along the lines of the next talk, which will take place on February 18th, if you're interested in registering for it. And now I'd like to wrap up and introduce Tasha Smith, who is the Vice President of Alpha Kappa Alpha Sorority Incorporated's Chi Omega Omega chapter, who is going to give us a few final remarks. Ms. Smith?
Good evening, good evening. On behalf of Target 2, Women's Healthcare and Wellness Chairman, and Louise Davis, Target 3, Building Your Economic Legacy Chairman, Debbie Williams and Keisha Dancy, the representatives from the University of Chicago Urban Health Initiatives, who partnered with us in hosting this program for the community. The moderator, Dr. Dorian Miller, our panelists, Dr. Kimbra Bell Baylark, Dr. Stephanie Crawford, and Dr. Richard Hubbard for sharing a wealth of information and preparing the Black community for the COVID-19 vaccine. From tonight's discussion, it is our hope that everyone is able to separate fact from fiction as it relates to the COVID-19 vaccine. We truly appreciate your continuous support of Chi Omega Omega chapter and the Imani Pearls Community Development Foundation programs. For more information, On future programs and events, please email our chairman at COO Women's Health and Wellness @gmail.com. You are all invited to attend our next webinar on minority representation in clinical trials, making your voice and your health count, on February 18th at 7:00 p.m. Also, please take a moment to complete the survey that has been placed in the chat. Thanks so much and enjoy the rest of your evening.